Welcome to the comprehensive 2021 World Health Organization Classification of Brain Tumors. This complete lecture covers all major brain tumor types, their molecular characteristics, diagnostic criteria, and clinical implications. Over the next 60+ slides, we will explore the complete spectrum of CNS neoplasms from diffuse gliomas to mesenchymal tumors, with emphasis on molecular diagnostics and clinical integration. This presentation is organized into 9 major parts. Part 1 covers adult-type diffuse gliomas, including diagnostic molecular assays. Part 2 discusses circumscribed gliomas, such as pilocytic astrocytomas. Part 3 explores glioneuronal and neuronal tumors. Part 4 covers craniopharyngiomas. Part 5 discusses ependymomas with their molecular subgroups. Part 6 covers embryonal tumors, including medulloblastomas. Part 7 explores mesenchymal tumors. Part 8 discusses tumors of uncertain differentiation. And Part 9 provides conclusions and future directions. Circumscribed gliomas contrast sharply with diffuse gliomas by forming sharp borders with surrounding brain tissue and not exhibiting significant microscopic invasion. These tumors are highly variable in behavior and prognosis. They include pilocytic astrocytomas, pleomorphic xanthoastrocytomas, and other entities. Molecular alterations drive classification and grading. Generally, circumscribed gliomas have better prognosis than diffuse gliomas. Pilocytic astrocytomas are the most common gliomas in children, accounting for nearly 20% of all childhood brain tumors. They typically occur in the cerebellum and optic nerve, but may also arise in other midline locations. The histologic spectrum is broad, but includes characteristic hair-like pilocytes and Rosenthal fibers. Molecularly, the most stereotypic alteration is a 3' duplication of the kinase region of BRAF, leading to a KI-AA FIND49 BRAF fusion product. NF1 loss-of-function events are also common. These tumors rarely reoccur after complete resection and are assigned WHO Grade 1. High-grade astrocytomas with pyloid features represent a newly added entity with a distinct methylation signature. These rare tumors have mostly been described in adults and typically arise within the cerebellum. Histologically, they show overlapping features with both pilocytic astrocytomas and glioblastomas. Genetically, they are characterized by activating events in the MAPK pathway, along with CDKN2A/B deletions and frequent loss-of-function alterations in ATRX. Prognosis is similar to that of grade 4 IDH mutant astrocytomas based on thus far limited follow-up studies. Pleomorphic xanthoastrocytomas are astrocytic gliomas with highly characteristic histologic features that frequently arise within the superficial cerebrum, especially in the temporal lobe of children and young adults. Tumors most often possess BRAF, P-V600E variations, and CDKN2A/B deletions. However, other MAPK pathway activating alterations have also been reported. These tumors are prone to reoccur and undergo malignant progression and may be assigned WHO grade 2 or 3 on the basis of mitotic activity. Subependymal giant cell astrocytomas are low-grade astrocytic tumors arising within subependymal tissue, typically in the lateral ventricles that are strongly associated with tuberous sclerosis. Although they are considered WHO grade 1, larger lesions may cause significant morbidity. Choroid gliomas are extremely rare tumors, most often located in the anterior region of the third ventricle, and carry a highly recurrent PD463H variation in PRKCG. Given the sensitive anatomic location of these tumors, they are considered WHO grade 2. Astroblastomas are rare glial neoplasms that typically arise in the cerebral hemispheres of female children and young adults. The histologic features of these entities are extremely varied and overlap with several different gliomas, embryonal tumors, and ependymal neoplasms. Nevertheless, they are characterized by recurrent fusion events involving MN1, often with BEN2 as its partner. Outcome data are limited given the rarity of these tumors. However, high survival rates have been noted. Glioneuronal and neuronal tumors show microscopic evidence of neuronal differentiation and are in general very well differentiated and indolent in behavior. Most demonstrate simplistic genomic profiles with single characteristic driver events. These tumors are often epileptogenic, and most are WHO grade 1. They demonstrate favorable outcomes following surgical resection. Gangliocytomas are rare epileptogenic tumors composed entirely of neoplastic ganglion cells that are most often seen in childhood. Although they may arise throughout the neuraxis, those associated with Cowden syndrome exclusively occur in the cerebellum. Diagnostic genetic alterations and profiles have not thus far been identified in sporadic cases. Gangliogliomas are biphasic tumors composed of both mature neoplastic ganglion cells and glial cells that are most frequently encountered in the temporal lobe of children. Gangliogliomas are characterized by alterations in the MAPK signaling pathway, with the majority being BRAF PV600E alterations. Tumors are usually indolent and correspond to WHO grade 1. Desmoplastic infantile gangliogliomas and astrocytomas are highly related benign tumors showing either mixed glial and neuronal features or purely glial morphology, respectively. These tumors characteristically occur as large superficial cystic lesions in the cerebral hemispheres of children under 2 years old. Recurrent activating variations in the MAPK pathway have been described, mostly within BRAF. Decembryoplastic neuroepithelial tumors are another type of benign epileptogenic tumor that present in the first 2 decades with medically refractory epilepsy. Tumors are usually cortically based and arise preferentially within the temporal lobe. Activating hotspot variations or internal tandem duplications of the kinase domain of FGFR1 are most common in decembryoplastic neuroepithelial tumors. Several additional rare glioneuronal tumors are included in the 5th edition of the WHO Classification of Tumors, which can show overlapping features and often require molecular testing for confirmation. All of the following tumors are WHO grade 1, and key differentiating features are highlighted. Papillary glioneuronal tumors are usually supraventricular and periventricular in location, and the diagnostic genetic event is PARK-CA gene fusion. Rosette-forming glioneuronal tumors arise in midline locations and prototypically exhibit FGFR1 hotspot variations along with PIK3CA alterations, NF1 alterations, or both. Myxoid glioneuronal tumors harbor PDGFRA variations at PK385 and most often involve the septum pellucidum and adjacent structures. As the name implies, diffuse leptomeningeal glioneuronal tumors grow preferentially and extensively within the leptomeninges. Diagnostic molecular features include gain of chromosome arm 1q and KAA549 BRAF fusion, although other MAPK drivers may be found. Multinodular and vacuolating tumors are epileptogenic hematomatous lesions characterized by frequent MAP2K1 alterations. Lastly, diffuse glioneuronal tumors with oligodendroglioma-like features and nuclear clusters are rare tumors that to date can be recognized only by their distinct methylation profile. Neuronal tumors include central neurocytomas, which are characteristically located within the lateral ventricles and show a tendency to reoccur despite their low-grade histologic appearance and are considered as WHO grade 2. Cerebellar liponeurocytomas are related entities that preferentially arise within the cerebellar hemispheres and exhibit a unique and defining adipocytic component. No defining genetic drivers have been identified thus far for these tumors. Despite their name, extraventricular neurocytomas are unrelated to the above tumors and show frequent FGFR1 TACC1 fusions. They also carry a WHO grade 2 designation. Craniopharyngiomas are squamous epithelial tumors that arise within the cellar and infundibulotuberal regions of children and adults. Adamantinomatous craniopharyngiomas are the most common subtype, which are characterized by keratin production, calcification, and recurrent activating variations in exon 3 of CTNNB1. By contrast, Papillary craniopharyngiomas lack keratin production, occur predominantly in adults, and harbor activating BRAF VOV600E variations, which render them particularly sensitive to targeted inhibition. In general, survival rates are high when gross total resection is feasible for these tumors. Ependymal tumors have undergone extensive reorganization in recent years and are now subclassified on a combination of histologic, molecular, and anatomic characteristics. Within the supratentorial compartment, recurrent fusion events in ZFTA or YAP1 identify two new subgroups, which largely occur in children and show distinct outcomes. Posterior fossa tumors fall primarily into two molecular subgroups. The posterior fossa A subgroup is highly aggressive and characterized by recurrent gains of chromosome 1q, but relatively few other genomic changes. The posterior fossa B subgroup, by contrast, usually shows whole chromosome gains and losses and is significantly more indolent. Both posterior fossa subgroups are reliably subclassified by methylation analysis, which is the currently preferred modality of testing. Not only does methylation array profiling generate subgroup information independent of copy number alterations, but the same test can additionally yield a copy number profile for further assessment of 1q and other arm-level gains or losses. In practice, immunohistochemical staining for the histone methylation mark H3K27ME3 can act as a quick and reliable surrogate for posterior fossa A versus B assessment in tumor cells. Spinal ependymomas of conventional histology typically harbor NF2 alterations, while those containing MYCN amplifications carry a much worse prognosis. Myxopapillary ependymomas characteristically occur near the conus medullaris, and their genomic profile is similar to that of the posterior fossa B subgroup. Subependymomas may occur in all three anatomic compartments and remain largely a histologic diagnosis with WHO grade 1 behavior. Grading of ependymomas on histologic grounds continues to be of questionable utility, as molecular profiling has proved more accurate at identifying tumors with significantly poorer outcomes. The term anaplastic ependymoma, as well as other histologic subtypes such as tannicytic, clear cell, and papillary, are no longer used. Additionally, myxopapillary ependymomas are now listed as being grade 2, given their high propensity to reoccur. Embryonal tumors are highly aggressive, poorly differentiated malignancies that frequently pose diagnostic challenges given their highly overlapping appearances. Most require comprehensive molecular testing for accurate classification. Medulloblastomas derive from cerebellar precursors and are one of the most common childhood CNS tumors. They are subclassified based on both histologic appearance and molecular profile. However, with the exception of desmoplastic and nodular morphology, other microscopic patterns do not correlate well with molecular classes. Current practice dictates assigning molecular subclasses when possible, which include wingless and INT1 activated, sonic hedgehog activated, TP53 wild type or TP53 mutant, and non-WNT, non-SHH groups 3 and 4. WNT-activated medulloblastomas arise in the dorsal brainstem in older children and young adults, usually harboring exon 3 activating variations in CTNNB1 or less commonly in APC, the latter of which may be encountered in Turcot syndrome. Immunohistochemistry for beta-catenin often shows nuclear positivity, although the focality and variability of staining usually require molecular confirmation. WNT-activated medulloblastomas have an excellent prognosis with standard therapy, with a 5-year survival rate of more than 90% and high cure rates. SHH-activated medulloblastomas occur in the cerebellar hemispheres with a bimodal age distribution in young children and young adults, usually harboring exon 3 activating variations in CTNMB1 or TP53 wild-type medulloblastomas generally have a good prognosis. Inactivating variations in PTCH1 are the most frequent mechanism of SHH upregulation, whereas variations in SUFU or SMO can be seen more often in adults. TP53 mutant tumors occur in older children and young adults and have a much worse prognosis. Gene amplification events, such as in GLI2 or MYCN, are more common in this subset of SHH-activated medulloblastomas than the gene variation events above. Group 3 medulloblastomas are the most aggressive subclass and occur most often in young children. Amplification of MYC is associated with this subclass. However, occurrence is infrequent. Few other readily testable genomic events define Group 3 tumors, which generally require methylation analysis for assignment. Group 4 medulloblastomas fall into Group 4, also non-WNT, non-SHH activated, and are typically seen in older children and adolescents with a 3.1 male to female ratio. The prognosis is favorable with standard therapy, and like Group 3 tumors, they require methylation analysis for definitive classification. Atypical teratoid rhabdoid tumors are CNS extrarenal malignant rhabdoid tumors encountered predominantly in children younger than 2 years old. Tumors may arise throughout the neuraxis, with frequent leptomeningeal spread at presentation. The histologic appearance of atypical teratoid rhabdoid tumors is highly variable, usually showing primitive tumor cells with at least focal regions of rhabdoid morphology. Loss of INI1 expression, or, rarely, of BRG1 expression, is required for the diagnosis, corresponding to biallelic inactivation of SMARCB1 or SMARCA4. Recent studies have identified 3 distinct transcriptional and epigenetic subgroups of atypical teratoid rhabdoid tumors, which show slightly different clinicopathologic features. The subgroups were assigned the terms TYR, SHH, and MYC to reflect the upregulation of genes related to melanogenesis, including the TYR gene encoding tyrosinase, the SHH pathway, and upregulation of the MYC gene itself, respectively. A typical teratoid or rhabdoid tumor TYR characteristically arises in the infertentorial region in infants, expresses melanocytic markers such as tyrosinase, and may have better survival outcomes. Embryonal tumors with multi-layered rosettes are highly aggressive primitive tumors that usually occur in the supratentorial compartment in children under 2 years old. They are defined by the amplification of a microRNA cluster on chromosome 19, designated C19MC, which usually results in the rearrangement of TTYH. The prognosis of embryonal tumors with multi-layered rosettes is uniformly poor irrespective of growth pattern, with an average survival time of less than 1 year. CNS neuroblastoma, FOXR2 activated, was discovered through large cohort methylation analysis of embryonal tumors when recurrent FOXR2 rearrangements were identified in tumors resembling extra-CNS neuroblastomas. Tumors typically arise in the cerebral hemispheres or subventricular locations, and the prognosis is not well characterized. FOXR2 alterations are generally not covered by most existing next-generation sequencing methods, necessitating methylation analysis for confirmation. CNS tumors with B-core internal tandem duplication are another type of CNS embryonal tumor identified by their distinct methylation profile. Tumors universally harbor short internal tandem duplications within the terminal exon of B-core. Occurrence within the cerebral and cerebellar hemispheres is most frequent, and they may appear well demarcated from surrounding brain parenchyma. The immunophenotype is nonspecific, and confirmation of the diagnosis requires next-generation sequencing or methylation testing. Although outcome data are limited, most tumors show aggressive behavior and rapid progression. Tumors of mesenchymal origin arise uniquely within the neuraxis. As a result, this section focuses on special grading considerations and diagnostic molecular findings for CNS tumors where appropriate. Meningiomas comprise the largest and most common mesenchymal tumor class arising within the CNS. These neoplasms may arise throughout the neurexis. However, the majority occur intracranially within the convexity and skull base. These tumors are most frequent in adult women, with a peak incidence in the 5th and 6th decades. The vast majority of meningiomas are slow-growing and indolent in behavior, corresponding to WHO Grade 1. When present, clinical symptoms are usually insidious in onset and related to compression of underlying structures. The risk of local recurrence is approximately 20% at 20 years, and surgical resection is often sufficient for long-term control. A small subset of tumors shows an increased risk of recurrence or frankly malignant behavior and may be designated as WHO Grade 2 or 3 respectively on the basis of various histologic and molecular features discussed below. Grading of meningiomas is performed via histologic assessment of several criteria, including tumor mitotic rate, brain invasion, and tumor necrosis, growth pattern, cellular density, and nuclear appearance. Myriad histologic subtypes of meningiomas have been described, many of which have been shown to correlate strongly with clinical behavior and possess unique genomic profiles. Secretory meningiomas are universally benign, frequently encountered on the skull base, and show characteristic variations in KFL4 and TRAF7. Angiomatous or microcystic meningiomas are also most often grade 1, and a large proportion of these show recurrent whole chromosome gains. Choroid and clear cell meningiomas are classified as WHO grade 2, irrespective of the presence or absence of conventional histologic grading criteria. Of these, clear cell meningiomas characteristically show SMARCB1 inactivation and may present as familial spinal tumors. Papillary and rhabdoid morphologic subtypes are definitionally WHO grade 3. A subset of rhabdoid meningiomas is associated with BAPI1 predisposition syndrome, showing loss of BAPI1 expression. Tumors with fibroblastic, meningothelial, or transitional histologies are most common and span all WHO grades. NF2 inactivation is the most frequent genetic finding in these tumors and is thought to drive tumorigenesis. Higher grade meningiomas show a stereotyped series of chromosomal changes, leading to the proposal of several new integrated grading schemas, analogous to what is currently employed in diffuse gliomas. Grade 2 meningiomas show highly recurrent chromosomal losses, of which 1p loss has been demonstrated repeatedly to carry independent prognostic value. In addition to these changes, grade 3 tumors show frequent homozygous deletion of CDKN2A, B, and TRT promoter variations. The presence of either or both of these events strongly correlates with grade 3 behavior, and formal assignment of WHO grade 3 may now be made in the absence of convincing histologic features. Although not yet employed clinically, distinct methylation subclasses of meningiomas have been described, which also show promising predictive value. Solitary fibrous tumors, formerly known as hemangiopericytomas, are meningeal solitary fibrous tumors that are dural-based fibroblastic neoplasms with clinical features that overlap with meningiomas. Like solitary fibrous tumors of the periphery, meningeal solitary fibrous tumors are characterized by NAB2 STAT6 gene fusion. Meningeal solitary fibrous tumors frequently reoccur locally, and distant metastases may present many years after initial diagnosis. Like meningiomas, solitary fibrous tumors may be classified as WHO grade 1 to 3 on the basis of mitotic rate and the presence or absence of necrosis. Additional molecular alterations such as TRT promoter and TP53 variations have been associated with more aggressive behavior, but these events are not currently assayed in routine clinical evaluation. Cerebral arteriovenous malformations are congenital vascular anomalies composed of malformed vessels exhibiting both arterial and venous histologic features with intervening brain parenchyma. Given their fragile vasculature, arteriovenous malformations carry a 2 to 5% risk of hemorrhage per year and a significant risk of death upon rupture. Cavernous malformations, by contrast, have no arterial or venous features and no intervening brain tissue. Although many are sporadic or arise following radiation therapy, familial forms exist and are associated with germline variations in CRIT1, CCM2, and PDCD10. Hemangiomas of the CNS are benign vascular neoplasms composed of various sized vessels that may arise spontaneously or in association with PIK3CA-related overgrowth syndrome. In adults, hemangiomas typically occur in vertebral bodies or the frontal skull. Hemangioblastomas are another type of benign vascular tumor characteristically located in the cerebellum of adults, and they are driven by alterations in VHL. Many bone and soft tissue neoplasms that commonly arise outside of the CNS, such as fibrous dysplasias, chondrosarcomas, osteosarcomas, rhabdomyosarcomas, Ewing sarcomas, mesenchymal chondrosarcomas, chordomas, and peripheral nerve sheath neoplasms, may present intracranially and will not be discussed further in this article. Tumors of uncertain differentiation include 3 new mesenchymal histopathologic entities that were introduced in the 5th edition of the WHO Classification of CNS Tumors. While all are very rare and their clinico-pathologic features are still being described, it is important to recognize how they differ from more common CNS tumors. Intracranial mesenchymal tumor, FET Krebs fusion positive, is a histologically diverse neoplasm characterized by the fusion of a FET family member, most often EWSR1, with a member of the Krebs family, such as KREB1, ATF1, or KREM. These tumors tend to present as extraaxial masses in the supratentorial compartment in children and young adults. The microscopic appearances occasionally correlate with a gene fusion product, and the immunohistochemical profile may overlap with meningiomas. Given this variable morphology and nonspecific molecular profile, the demonstration of a FET-Krebs gene fusion must be integrated with the appropriate clinical and histologic setting to establish the proper diagnosis. The behavior of these tumors is unclear given the small number of described cases and varies from indolent to rapid recurrence. Primary intracranial sarcoma, DICER1 mutant, is another diverse entity that encompasses histologies such as gliosarcomas, glioblastomas, embryonal chondrosarcomas, rhabdomyosarcomas, and primitive neuroectodermal tumors unified by their methylation pattern and DICER1 inactivating variations. These tumors have been described in both adults and children, where they may occur sporadically or in the setting of both DICER1 syndrome and neurofibromatosis type 1. Although these tumors likely follow an aggressive clinical course, more data are required to determine their natural history. CIC rearranged sarcomas are high-grade round cell mesenchymal neoplasms, more often arising in younger patients outside of the CNS, but may rarely occur within the brain as well. These sarcomas possess a characteristic fusion of CIC with various partners such as DUX4, which is more common outside the CNS, or NuTM12, which is more common inside the CNS. In addition to detecting the diagnostic fusion event, immunoreactivity for ETV4, WT1, and CD99 may be used to confirm the diagnosis. The outcomes of CNS CIC rearranged sarcomas are not well described. However, initial reports as well as literature from extra CNS tumors suggest an aggressive course and poor response to therapy. The diagnosis of brain tumors has shifted dramatically from strict reliance upon traditional light microscopy to pervasive integration with both genomic and epigenetic molecular findings. Molecular alterations increasingly dictate diagnosis and prognosis. The classification system continues to evolve as data accumulates and our understanding of tumor biology deepens. Integration of histology and molecular features remains essential for optimal patient care and treatment planning. The 2021 WHO classification represents a comprehensive paradigm shift in how we diagnose and classify brain tumors. Molecular diagnostics are now essential for accurate classification of most tumor types. Multiple assay platforms are available for different diagnostic contexts, including immunohistochemistry, FISH, PCR, chromosomal microarray, next-generation sequencing, and methylation profiling. Prognosis varies significantly by molecular subtype, and treatment planning is increasingly guided by molecular findings. Emerging targeted therapies are being developed based on specific molecular alterations identified in brain tumors. For example, BRAF V600E mutant tumors are sensitive to BRAF inhibitors, and IDH mutant gliomas may benefit from IDH inhibitors. The integration of molecular diagnostics into clinical practice has already improved patient outcomes in many tumor types. Pathologists must master molecular diagnostic tools and their interpretation to provide accurate diagnoses and prognostic information to clinicians.